Welcome to JoyMed podcast, brought to you by Safe Haven, a program of the Medical Society of Virginia. I'm Melina Davis, your host. I'm the CEO and EVP of the Medical Society of Virginia. We're thrilled to announce the launch of this new podcast series, where we'll delve deeper into the challenges faced by healthcare professionals, explore strategies for resilience, and highlight the support systems available to them. Each episode will feature expert insights, personal narratives, and practical tools to help foster a healthier, more supportive environment for our healthcare heroes. Make sure to subscribe to our podcast so you don't miss this important series, and share it with your friends and colleagues. Together, we can create a culture of care and support, ensuring that those who care for us are cared for as well. Thank you for listening, and we look forward to continuing this journey with you. Hello, and welcome to JoyMed. I'm Melina Davis, your host. I'm the EVP and CEO for the Medical Society of Virginia. JoyMed is a podcast of the Medical Society of Virginia dedicated to discussing and exploring burnout, clinician well-being, and solutions designed to bring joy back into the practice of medicine. And today, we are so fortunate to have with us somebody who I treasure, really personally and professionally, Joel Bundy, Dr. Joel Bundy, who is the Chief Medical and Quality Officer for Sentara Health. And he's also the current president for the Medical Society of Virginia. Joel, welcome.
It's so good to be here. Thank you very much.
It's been a whopping, less than a month since you've been president. So you're a green president at this stage. We can't even say you're green. You're such an experienced physician, but also hospital administrator. You're the first hospital administrator in a current role to be president of the Medical Society.
It's an incredible honor. I never thought that this would happen. I'm very, very excited. I do think it brings additional responsibilities to make sure that I'm not the last hospital administrator who's the president of the Medical Society. But yes, I'm very excited.
Well, before we go too far, let's explore why you're the first. I get the opportunity in a speech I do every year at our annual meeting to talk about the incoming president. And the thing that I try to emphasize is the reason that I believe that you're president first as the first administrator is because of the incredible level of trust that you've built with people. You care about patients, you care about your colleagues, and you care about APPs, and you run a healthy, safe, positive work environment that gets good healthcare outcomes.
Right. I think that's incredibly important. It's one of the huge reasons why I went into administration is because it did give an opportunity. I've been on both sides of the fence. I've been on the clinician side at the bedside, making rounds, going to the heart hospital at 2 a.m, understanding what it's like to be in an environment which is sometimes unhealthy. Well, how do you fix that? Well, sometimes it's easier to fix it on the inside. So working on the inside to change systems really, I think, is incredibly important. But yes, it's part of my true north. So thank you for bringing that to my attention.
Well, I love that you've built some real trust. We've known each other almost a decade now. So, I got to witness your journey of building that trust with your colleagues. And I'm not sure it's easy in a place where you are a practicing physician and moving into that administrative role to maintain that camaraderie and sense of collegiality and trust with your colleagues, right? Why is that?
It's hard because, often in a role where you have positional power, you have to make hard decisions. Mm-hmm. And so sometimes people will say, well, I don't like that decision. And I think that was pretty common during the pandemic. You had to make some really tough decisions based on incomplete information. But I think that when people realize you were doing the very best you could with what you had, and that you communicate, this is the why we're doing this. I think that really helps. And it's just, I think to be an effective administrator, you really have to have integrity, because as soon as you don't, I think people will stop listening, will stop following you, and then you're not going to be successful. So you have to have that honesty in who you are, and be able to present yourself as a honest, truthful person, because administrators are often not thought of as truthful people. So it really is important to make sure that you consistently show that that's who you really are.
Do you think that any of your colleagues ever felt like you sold out to the other side?
Well, yeah, I hear that all the time. I've gone to the dark side. And in fact, I remember going to a Christmas party as Darth Vader before. Oh, no. And but I think that over time, people realize that, you know what, he's really trying to make things better for us. And I'm glad he's there, because, these are hard decisions to make, and somebody needs to be there. When you think about administration, it's not just the physician executive. You've got the nurse executive. Yes. You also have operators. You have people that have MHAs, or they're, let's say, maybe a hospital president or your CEO. And if they're not clinicians, it's incredibly important to have the voice of the clinician there at the table.
Right.
Because if you don't have that voice at the table, then sometimes decisions that are made without, and they're often made for good intentions, but the downstream impact is not well thought out about what is this going to impact the nurse or the physician at the bedside, and how's that going to look. So I think it's important to have that voice.
It is important. I'm sure then you feel the pressure from the other side, the administrators, or like, he's one of those people.
Sure, yeah. Well, I love, one of my favorite books is Maxwell 360 Leadership.
Yes.
And he talks often about you have to be able to manage not just yourself, but you have to be able to manage up and across and down.
Yes.
But at the same time, if you want to be cynical and think about it, all those people look at you, whether they're the people above you or your peers or even the people that report to you, they may not trust you. So it's important, I think, to be able to work very, very hard to manage all around.
Yes, yes. One of the things, that I've noticed as you've built relationships over the years with people is that you genuinely care about people. And you genuinely will stop and listen to the human that's sitting next to you and what they are dealing with and their stress. I think that's gone a long way. And you've done that consistently. So people don't just trust the doctor or the administrator. They trust the human because you're kind, frankly, and care.
I said this at the inauguration, but and many people may not have known this, but when I was in high school, the first university I went to look at to go to college was seminary. Yeah. And that's just who I am. Now, at the end of the day, I love science way too much, but that part of this is who I am. I want to help people. I want to make things better. It's really been an important part of being a physician. So that piece, understanding the science, understanding the physiology, being a nephrologist is incredibly exciting and wonderful work. But at the same time, we're taking care of people.
Right.
And not just the person that you're talking to who may have chronic kidney disease or ends up on dialysis or needs a kidney transplant, but you've got the family, the impact on the family. And I think that all of us are very complicated people, but many of us in healthcare, we really do have a calling. It really is. Yes. It's something, it's a powerful, powerful emotion to know that I'm here because I want to make things better for patients, for families, for the community. So,
it's fun. I was at your inaugural, clearly, and I was struck that your brother and you are very close.
Yes.
He, in fact, did induct you in many ways and was part of that. But he's also a scientist for NASA.
He is,
right?
Yes.
It's interesting that you both have that science background, but yet I recognize the personality in him. I don't know him as well, but also very human-centered and very kind and generous. It's interesting that you both share that
Yeah, we're very, very similar, and that's scary for me. He's my little brother, but yeah, we're similar in that regard. And because we're similar, he's someone that I can reach out to when I'm struggling, and he can reach out to me when he's struggling. But we've done lots of things together, had a lot of life that we've shared on the really, really positive and the not so positive. Yeah.
Yeah.
Mom and Dad both passed away within a few months of each other during the pandemic, and it was really, really hard. And I think that it made it more important to remember that we have to lean on the people that are near us, that we love and love us back, whether that be someone professionally that I'm close to, or maybe a system that's built. In this case, it's my little brother.
Yeah.
Well,
it's not just one person, right? And it's not just one aspect of our life that we have to make sure that is, I want to use the word balanced, but balance implies sort of this, it's always in balance. Life, you're never in balance, right? But we need sometimes different levers. Sometimes it's our brother. Sometimes it's the wellness officer at our hospital. Sometimes it's a colleague to help rework things to get them back in middle balance.
Yeah. And often for me, especially after a really difficult day, I'll go home and it's my wife, Susan, who sort of helps level things out.
I adore her.
Yeah, me too.
I adore her. Well, and it's interesting because I think a lot of physicians, particularly physicians who wear multiple hats, like you do, have a tendency not to have as many close relationships and people to depend on. At least from my observation, have you seen that in your colleagues?
I have. I think it's incredibly important that we have people in our lives that we can just say, I'm really not doing well today. Can we talk? And unfortunately, physicians and other healthcare clinicians, we work really hard. And sometimes we do that to the detriment of our own well-being. I'm sure we'll talk about this, but we have focused for so many years in leadership saying, well, hey, Dr. Bundy, you need to take care of yourself. You need to do more yoga. Don't have that second drink of alcohol.
Right.
Make sure you get some sleep. And we would lead with that. And that's important. But it's also important that we build a system that's an effective, efficient system.
And healthier.
Full of joy.
Yeah.
I mean, because if we only talk about self-resiliency, we're not going to be successful.
Right.
We have to build an entire system that works for people.
Yeah. And it's two-sided, right? There's self and environment, right? And it's this network of care that you can turn to depending on what you need, right? To help rebalance.
Yeah, absolutely.
Because if we don't know how to ask for help and the help is there, then we don't accept. If we want to ask for help and we're not allowed to, or the environment isn't ready for that, right? That's equally as bad.
Both of those are incredibly important to think through.
Yeah.
And for a long time, physicians in particular, we don't ask for help.
Right.
And sometimes it's because we know there's something out there, but we don't think it's for us. And you know what? Because it wasn't built for physicians.
Right.
So we don't use that. And at the same time, physicians have often felt that if they did ask for help, what's this going to do to my career?
To my record.
I'm going to have this mark somewhere in my record so that if someone's going to see that, and are they going to take my license away?
Right.
If I decide to move to another state, can I get a license there? Will a hospital be able to credential me because I've got this scarlet letter somehow in my record? And that's not necessarily true, which is why I think that building those safeguards as we've done here with the Medical Society of Virginia around Safe Haven, that's been a game changer, I think, for many physicians.
As has the change in credentialing and licensure that, I have to give a tip of the hat to the Dr. Lorna Breen Foundation for their work with that. I mean, all of these things are making sort of the systematic pieces better. But inside a work environment, you've also been working on those internal systems as well.
Right, yeah. And there's so much to do, from building huge programs to doing just simple things. And sometimes the simple things are just listening to people, going where they are, asking, hey, in this environment, in the emergency department, what's wrong? What can I do to fix this? Or just build an incredible system. Or like with credentialing, why are we asking questions about, have you ever felt depressed, ever in your entire life? Well, we don't need to do that. So, let's get rid of it. So there are things that we can do, both big and small. Once you do those things, and this is hard. How do you then not just communicate, but effectively communicate that to the people you've just helped?
Yes. So they know.
Yeah. I mean, so sending an email out to 30,000 employees, wow. I mean, that's not going to be effective. It's going to touch some people.
Right.
Sending an email out to 6,000 physicians and APPs, some of them will read it, but you have to get out there and venue after venue after venue and talk and listen, make rounds, tell people where they are. That's the only way that people actually know, wow, you did that?
Right.
You've actually been working on the electronic healthcare record, which is the bane of many people's existence.
Well, everybody believes it's the core of the problem.
I know. And it is part of it.
Not the only.
There's a lot of inefficiencies we have in healthcare. But as we fix those things, then we have to tell people, hey, we fixed these. And, oh, by the way, can you think of something we can do to make it better?
Right.
I know.
Right.
We often think about, I'm a big fan of high reliability because I think that's how we impact safety. So some of the principles of high reliability are deference to expertise. Well, as an administrator, I'm not there at the bedside anymore at 2 a.m. So what is it that someone who is there can tell me that I can do to simply, hey, make this change?
Right.
It'll be better.
Right. And at 2 a.m., that's probably a nurse, right? Or
probably,
a PA, right? Yeah. Or an aide even. And listening to all those voices. And to go back to the earlier comments about trust is built by repeatability, right? By being able to rely on a culture and system to repeat its openness to listening and to then solve not one problem, but 2 problems, 3 problems, and consistently do that, right?
It's true. Trust is so important. And I read again the other day, and I'd forgotten this phrase. Someone had said, trust is built in inches and lost in miles.
Yes.
So it's incredibly important for those of us in leadership to remember that, to always make sure that we are thinking about how do we come across, what am I saying? You cannot be duplicitous. You have to be straightforward and talk to people about what the truth is and what are the barriers. And I can try to fix things and solve things, but some things can't always easily be solved, or they're going to take time.
They just take a lot of time or are out of your control. One of the things I've noticed is sometimes if people have an issue and they go to somebody and they get the pat on the back, yep, I'll think about that, I'll talk about that, but nothing happens, right? That is the kind of moment when trust is lost, when that person can't be relied on regularly, right, to resolve an issue, even try to resolve it. What happens when you are the person who can and consistently resolve, but one day cannot? How do you deal with that in the trust in a relationship?
You tell them.
You just tell them.
You know what? This is either out of my scope, or it's bigger than me alone, or this is going to take talking to many other people to try to change things. We can influence at the General Assembly, let's say, or influence, at the federal level, influence other systems or other hospitals. But, it's the same thing when we talk about social drivers of health. We often will talk about, well, hey, your quality in your hospital is X. But when you think about it, really only about 15 to 20% of the outcomes are due to the care in the hospital.
Right.
The rest are out in the community. Yeah. There's a lot of things like that when we try to fix things that they're just out of
Your
the
scope.
ability to do.
Yeah.
But that doesn't mean we can't try.
Right.
And sometimes, let's say with the electronic healthcare record, we have to do these things. But there are things that we can do. I think often about, in this patient safety world, we think about, hey, let's do what we call a best practice alert. So if I'm the clinician, I'm in there in the record, and maybe I've gone a little bit off or something, there's an alert that pops up. Well, how often do those alerts, are they really helpful? Are they effective? Are they efficient? And it's easy to say, hey, let's just put another alert in there because that's going to stop people. And what happens is you put too many alerts in there, people stop looking at them because they're white noise. Yeah. So one of the things that we did in Sentara is we said, well, let's look at those alerts. And maybe we don't need all of those because they're not really having an impact. They're not really doing what we thought they would do. And so we've eliminated them. And by doing that, if you think about, well, you say, well, it's just one little click.
It's small.
But one little click over time equals hours and hours and hours. So there are those little things that we can still do.
Yeah. So when you hear about stressors from clinicians, doctors, nurses, PAs, anybody in that team, what stands out? What are the big things that they're talking about that are stresses in their life? And then I'm going to ask you about the administrator viewpoint, because I really want people to see that there are stressors on both sides, but that they might not be the same kinds of things.
Yeah. What I hear often is that there are things that people are asked to do and they may not know exactly how to do it, especially with many of our new nurses. We, during the pandemic, we lost a lot of nurses.
Yes.
And now we're doing a really good job of hiring nurses. So we have the numbers, but they're all so new and they don't have that lived experience to know, I've seen this 4 times before. I know how to manage that. And so you have a lot of new nurses, and so they struggle sometimes with knowing exactly what to do and how to do it. I also think that we continue to struggle from a team standpoint. So whether it be in the operating room or on the floor or at nighttime, do we function as a team?
Yes.
Or do we function as individual silos? Physicians and nurses and PAs and respiratory therapists, how well do we function as a single unit? I think it's easy to talk about that in the operating room, but it happens everywhere. Because if we're not functioning as a unit that's a seamless unit, we're going to make mistakes.
Absolutely.
And so I think that people find themselves often functioning independently and not as a team. And that's really hard. If you're in the emergency department, you're often overwhelmed with the number of people there. And so you'll have people sitting in gurneys waiting to go up to the floor.
Yes.
I think those kinds of stressors where people are like, what do I do? I'm overwhelmed. And I know for physicians, often when people feel like, I'm not only overwhelmed, I have no impact on fixing any of this. That leads to burnout.
Yeah. Because there's an emotional impact, not just an intellectual, situational impact, right?
Yeah, absolutely.
There is an emotional effect that we as humans have, particularly if it happens over and over and over, like it would in war, right? Where you're constantly bombarded, right? You get worn down.
Yeah, you do. We think a lot about PTSD, but I think that if you're going into an environment that is just difficult, very, very hard, and you see the same types of things that you struggled with last week and last month and last year, and they haven't been fixed, it makes it really hard to want to go back into work again. I don't want to go into that environment because it hasn't been fixed. And if you think about, I talk a lot about the emergency department, but when you look at the Medscape survey, typically ED physicians are at the top of the list when it comes to burnout. So I think that's a unique environment, but we see the same thing in other places as well. Yes, absolutely.
Right. What about administrators? Because I know they feel that there's so much pressure here, and you've got one foot on both sides.
It's really hard because as an administrator, not only do you have to think about the clinicians and how the work goes in the hospital and making sure you have high quality care, really good patient safety. But you're also, as an administrator, you're thinking about employee safety. You know, we think workplace violence is a huge, huge issue. So we're trying to fix that. And then you think about, you have to have some fiduciary responsibility. You know, there's only so much when it comes to money and resources. And how do we effectively use that? An easy answer is, well, let's hire a lot more people. And sometimes that is the right answer. But sometimes hiring more people into an inefficient system isn't going to work either. So you've got all these different things. You've got operational issues. You've got human dynamics. Anytime you get people together, you're going to have dynamics. And often they're great, and sometimes they're not. So administrators are constantly juggling all of those issues. And, you know, sometimes to solve those things, it's you have to have difficult conversations with people. And many of us as human beings, we're conflict avoidance. We don't like to have those conversations. And, well, there are ways to do it, though.
Right.
And so, one of the things as an administration is you're taught how to have a conversation with someone where you make it not personal.
Right.
You talk about behaviors. Or how do you have a conversation where you actually sell a program change that, do you know how to do an ROI? There's lots of different pressures on administrators to try to do things more effectively. And I think that physician executives, one of the problems with physician executives, and my own personal experience, is that sometimes we find ourselves in a job and we're like, oh my gosh, I don't know how to do this. We're often very, very good physicians. Yes. And then the next thing you know, you're a chief medical officer. How do I do these things? I remember a long time ago now, I probably wasn't paying attention. And the next thing I knew, I was the secretary of a department of medicine at a community hospital. And
Boom.
Then the next thing, now I'm the department chair, and then I'm on the MEC, and now I'm the president of the medical staff. And
you got trained, I'm sure, for every single one of those roles.
No, not at all. And so and then the next thing you knew is like, I was thinking, I really want to have a bigger impact than even this. So maybe this chief medical officer position is what I want to do. And I think one of the important things about being a physician leader is having a good mentor.
Yes.
And for me, that was Dr. Romero, Dr. Sin Romero. I think many people listening to this will know Sin.
Yeah.
But and she's been my mentor in helping me along the way. But it's true that, as you change your leadership role, often we're not prepared. So nurse executives, their entire career, they've been preparing for leadership and increasing leadership. Physicians, often we don't have that. So it's important that one have education, training, mentors, those sort of things, so that you know exactly what you're trying to accomplish.
One of the reasons that the medical society and so many organizations in organized medicine actually concentrate on leadership training because physicians don't get it. You don't get exposed to some of this human-centered business training, but yet we need more doctors at the boardroom tables, at the government tables, so that when you get to that downstream effect, right, you had the knowledge at the table to contribute.
I look back, and that's a great point you bring up, the Physician Leadership Institute, which we have now.
Yes.
I remember going to the old PLI, which we called the Claude Moore.
The Claude Moore, yes.
And again, I went because Dr. Romero said, this is something you should do, Joel.
Yeah.
And I remember, wow, okay, I'm learning these business principles, operational principles, how to build teams, all of those things. That was incredibly important to make sure that we had that kind of training. Now, obviously, in my role, I've had a lot of other training since then, but that was an important part of my journey to start there and to learn those principles that I can then move forward with. So.
Yes. Well, it's so interesting because my educational track, I think I started leadership training at age 12. I don't understand why I did, but that was just part of my educational journey. And it was shocking to me to arrive at the Medical Society after my MBA and after working as an entrepreneur to realize that I had knowledge about something that wasn't commonplace in this environment, which had made me sort of an ugly duckling, actually, in that environment to begin with. But I realized, I needed to share.
Sure.
Because it was a missing component, and it was clear to me, but it wasn't clear, I think, to the masses that we needed it. It was clear to people like you who'd gone through PLI, and to Sin who'd gone through PLI. And now it's a major component of what we do because you don't get exposed much.
No. And there are so many opportunities for physicians, but many of them are about changes in leadership. We absolutely need to have that brilliant physician at the bedside so that, and I'll share the story. I remember it was very surreal, and it was before I became a chief medical officer. I was cooking dinner, and then I had this pain in my left shoulder. What is this? And the next thing I knew, I was in the ambulance on the way to the hospital. And I remember after my cath and after my cardiac stent, sitting in the coronary care unit and counting the tiles in the ceiling and listening to my heart on the monitor. And I remember when my cardiologist would come in, I would say, I'm so glad you're here because you are brilliant and you're going to take great care of me. And the nurses would take great care of me. We need to make sure that we have incredible, gifted physicians at the bedside. But we also need to make sure that we have people in other areas, whether it's a chief medical officer or a medical director, or whether you're the physician on television with CNN, it doesn't matter. All of those different roles, I think we're talking about the house of medicine. Well, the house is pretty big.
The house is big,
yes.
This idea of this team dynamic, so very important for leadership, but also efficiency and positive outcomes, right? You learn about this getting your MBA, of course, is this idea of high-performing teams. And teams are thrown together in healthcare. They're not always a unit that always work together, right? So you have to be highly adaptable as well to become an instant member of a team that then performs highly. That must be very difficult to manage.
It's very difficult. I mean, sometimes there's teams where you want to fix a program and you can self-select and, you can work on that. But sometimes it's the team in the operating room. And, where I hear, and again, going to operations and how do you solve for this, it's very difficult. But if I'm in a long case and I'm the surgeon and I know everybody in the room, and then, now it's lunchtime and people move or the shift change.
Yes.
And now the team that I've been working with for the last 90 minutes, they've changed over.
Right.
So the dynamics change in that team. So there are clearly things that we can do to try to make teams better. But if we have an ineffective team or a dysfunctional team, it's going to cause patient safety issues, or we just aren't going to get along very well.
Right. Makes it harder and adds to
stress.
stress.
I think many of us have read the dysfunctions of a team, 5 dysfunctions of a team.
Let's hope.
It's very, very true.
Yes.
Yeah.
So we talk about, clinician burnout a lot on this podcast. What about administrator burnout? Do you see burnout in your peers?
Oh, absolutely.
You do.
Yeah.
And you've experienced some of this, I know,
have.
from conversation.
Yeah, I have.
What does that look like?
It's hard, and often because we believe that we can do it, we don't share with each other. And I think that's the same thing that other people, who am I going to share with? If I share how I'm feeling right now, will I lose my job? So I think, going back to team, having peers that you can talk to say, it's not been a good couple of weeks for me. Because we don't know what's happening with other people.
Right.
I talked about my parents passing away within a couple of months of each other. It was a hard time.
Yes.
A really hard time. I know some of my peers have gone through a divorce, or financially they're not doing well, and there's a lot of pressures outside of work. And sometimes work itself, as I mentioned, the work I do is very, very difficult, and I don't always feel like I have support, but I do.
Right.
But I've got to reach out and get that support. And sometimes the support is inside the profession. Sometimes it's at home.
Right. Which is why we need to have all of that sort of network of allies and relationships, right?
So the things that we talk about for clinicians at the bedside, I think of the Stanford model for resiliency. It's not only my self-care, which is incredibly important, but it's also those other two legs of the stool, having a culture of wellness, having psychological safety, and then also having efficient process. Right. So you have to have all three of those, and without one of them, you're not going to be successful. So I think that for administrators, making sure that for ourselves we have efficient process, we have a joyful work environment, and we're taking care of ourselves. Right. And then to be able to reach out to other people. I think we're blessed in Virginia from my standpoint. I have a lot of good peers, both within Sentara, but also outside of Sentara. And it's not uncommon for me to reach out to someone at UVA or at Nova or Carillion or Ballard and say, hey,
how's your day?
Can we just talk?
Man. I love that. I think there is this idea that you can easily get isolated no matter what role you have, and that the more stress that you have, the more isolated you can feel, right?
Right. It's true. But then at the same time, you think about, oh my gosh, think of all the incredible things we get to do. I love taking care of a patient on dialysis, one patient at a time, one family at a time. But I love taking care of an entire community and changes that I can make in my office. Now, obviously, you don't make those by yourselves. You work with a team, but you can make changes that impact tens and hundreds of thousands of people. Yeah. That's incredible. So sometimes it's important to remind ourselves of the good things we do. Whether I'm a nephrologist taking care of a patient with lupus, or I'm the chief medical and quality officer for Sentara Health. Just we do incredibly wonderful things. But at the end of the day, I can go home and say, wow, I'm blessed.
Yeah. If you could give one piece of advice to administrators on how to make their lives and their work more joyful, what would it be?
I think that they need to have someone they can reach out to. That's probably the most important thing, because it gets lonely. So having someone that you can reach out to, and for me, it's often Dr. Romero. Hey, Sin, but having that person that can remind you of how much good you're doing, and it's because sometimes you just feel like you're beat down all the time, and it comes from everywhere, right? Yes. But to be reminded of all the incredible things that you're able to do, but also to just have someone to talk to. Yeah.
And is that the same piece of advice for clinicians?
Yeah.
It sounds like human advice.
It is. Right. It's going back to wanting to go to seminary, right?
Yes.
We're all in this together. We're all humans. We need to support each other.
Yes.
I think it's a beautiful thing that we have in Virginia and healthcare in Virginia. I love where we're going. I love the things that we've been able to accomplish. And I just need to remember sometimes that that's what we're doing. Yeah.
I love talking to you. It's always such a gift to spend time with you, Joel. And I'm so grateful that you're our president this year. Thank you for taking time today.
Oh, you're welcome. It's good to be here. Yeah. Thanks, Melina.
Thanks. Thank you for listening to JoyMed, a podcast series I think you'll find very interesting and compelling, all dedicated to making our healthcare workforce healthier. Come back and hear us soon.